Welcome everyone. Hope you are all doing well. We have already in the past shared videos of different diagnostics which we commonly use in retina. Especially, we shared a video on OCT and OCT angiography. Continuing with those same type of videos today, from today I start sharing a series of videos on FFA. So this is the first part, and this video presentation is primarily made with general ophthalmologists, young medical retina practitioners, and optometrists in my mind. So if you are, for example, a lay person, you may find this video very technical. So in this first part, I will try to cover three questions, or try to answer three questions. What does FFA stand for? How we do FFA, and how we interpret FFA in our clinics. So the first thing first, what does FFA stand for? So FFA basically stands for fundus. The first F is for fundus, which is the interior posterior surface of the eyeball, which includes the retina, the optic nerve, macula. The second F stands for fluorescein, which is a vivid yellow-green dye which can fluorescence. Now, what is fluorescence? Fluorescence is a phenomena where some objects or materials, when they are excited by a particular wavelength of light, emits a different wavelength of light. For example, the fluorescent dye, when it is excited by a blue light, it emits green light, and this phenomena continues as long as the dye is being excited. So once you switch off the blue light, it will stop emitting the green light. So the first F was for fundus, the second F was for fluorescein. The third letter A stands for angiography, which basically is of two words: angio, that is blood vessels, and graphy means photography or documenting the blood vessels. So basically this is a technique to image blood vessels, just like you have carotid angiography, coronary angiography. So we have fundus fluorescein angiography, where we are using a dye to document the flow of blood predominantly inside the retinal blood vessels. Now for choroidal blood vessels, we have a different diagnostic test called ICG angiography, indocyanin green angiography. Maybe we can have, we will try to make a video of that sometime in the future. So the next question is, how do we do FFA? So once a person has been advised fundus fluorescein angiography, the first step is to take consent, because fundus fluorescein angiography is an invasive test where we have to inject something inside the patient's body, and therefore it is important that we explain the entire process to the patient, the risks involved, and then take his or her permission before proceeding any further. The second step is to send the patient for a general checkup, and we need to specifically rule out three things. One, whether the kidneys of the patient are working properly or not, because the dye that we inject in fundus fluorescein angiography is excreted through the kidneys. So if a patient has severely compromised renal parameters, it is safer to take the opinion of a nephrologist or physician before proceeding with the test. Though, please keep in mind that just a slightly elevated creatinine is not a contraindication for doing angiography. And additionally, today we have an alternate way to study the retinal blood vessels, that is OCT angiography, which is a dye-less technique. And sometimes in this kind of situations where the renal parameters are deranged, probably it can be a safer alternative than fundus fluorescein angiography. The second thing, of course, we have to rule out is pregnancy, which is an absolute contraindication for fundus fluorescein angiography. And third is, we need to look for history of allergies, because people who have history of allergies, they might react to the dye itself, because reactions or sensitivity to the dye is reported, and reactions to this dye or allergic reactions to this dye can vary from mild itching to severe anaphylactic shock. Therefore, we need the patient to be seen by a physician, and we need to rule out these histories of allergy or before we proceed to do the fundus fluorescein angiography. Now, some places we also do a so-called skin test. That is, we inject a small amount of the dye subcutaneously to look for a possible sensitivity to the dye before we proceed with the test. But there is a lot of controversy around it. Some say that this subcutaneous test is actually not very practical. It doesn't really rule out the possibility of a anaphylaxis once you inject the dye intravenously. Some also say that if a patient is really sensitive to the dye, even the subcutaneous injection can also cause a reaction. So that itself is also risky. So we need to take or keep a general physician in the loop before we do an angiography to be on the safer side. Now, once all these two steps are over, the third is that you have to ensure that the patient is on empty stomach or rather has not eaten at least within last 2-4 hours before the test. Why so? Because one common side effect or complaint of patients, especially young patients who are undergoing fluorescein angiography, is that after the injection of the dye, they often complain of nausea or sensation of vomiting. Now, if a patient has eaten, it's very likely that he or she may actually vomit. Therefore, it is safer to keep the patient on relatively empty stomach before doing the test. Next, you have to dilate the pupils. There are now ultra wide angle cameras, ultra wide field fundus cameras, which can take very good wide angle or ultra wide angle images through undilated pupils, non-mydriatic ultra wide field cameras. But when we are doing angiography, since it's an invasive test, we really don't want to compromise on the quality of the images or miss out on any area. Therefore, it is recommended that we dilate both the pupils, both the eyes, dilate the pupils of both the eyes, and not try to do an FFA through an undilated pupil whenever possible. Now, even if the disease is in one eye, we usually dilate both the eyes because of the same reason, as I said, that it's an invasive test. You can't keep redoing the test again and again. And it is said that you shouldn't repeat the FFA within 3 months. Therefore, dilate both the eyes and then proceed with the test. So once you have done all these tests, next you need two things to actually do the angiography. First, you need what we call a fundus camera with facilities for fluorescein angiography. So at the Retina Institute of Bengal, we have two such cameras. One is the Spectralis from Heidelberg Engineering. The other is the Claris 700 ultra wide field true color fundus camera from Zeiss. Both these cameras are capable of doing fundus fluorescein angiography. Second, you need the dye, the so-called sodium fluorescein dye, which comes in ampules like this. Now, this is an orange water-soluble dye, and usually 2 to 2.5 ml is injected intravenously and slowly. So here, both these two words, I'll like to share some more data. One, when injecting the dye, please we have to ensure that the needle with which we are injecting is inside the vein, because if the needle punctures the vein and the dye somehow goes outside the vein, that is, there is extravasation, then this dye can cause severe painful reaction. So we definitely need to ensure that the needle is inside the vein and not outside. Second, the dye is ideally injected slowly, because if you inject the dye in a sudden bolus, the chances of the patient having a nausea or feeling nauseous is much more. Therefore, inject the dye smoothly and slowly. Now, once in the blood, 80% of the dye gets bound to the proteins in the blood, and only 20% remains free within the plasma. The dye cannot leak out of normal retinal blood vessels or cross normal retinal pigment epithelial barrier. And as already said, it fluoresces, and therefore when it is excited by blue light, so if you inject the dye and then throw blue light onto the fundus, the dye will emit a green light, and the fundus camera has some special barriers, filters, to ensure that the blue light you have thrown inside the eye is not reflected back to the imaging sensor, and some special filters ensure that only the green light emitted by the dye is picked up by the camera. And as already discussed, that this and already as I have said, that this dye is excreted in the urine over 24 to 36 hours. So you must tell the patients that it is likely their urine will be discolored for 1 or 2 days, and that's absolutely fine. They need not worry about it. So now your patient is ready. Pupils are dilated. You have ruled out hypersensitivity or pregnancy. You have taken general patient informed consent, as well as you have asked your patient has gone through the general physician checkup, and now the patient is sitting in front of you on the camera, ready for the procedure itself. So how do we do that? So once the patient is positioned at the camera, we inject the dye through a scalp vein typically placed in patient's arm, and as I've already said, that the injection is given slowly inside the vein, and then using the camera, a series large number of photos are taken in frequent intervals to basically record the flow of the flow of the dye through the retinal blood vessels. For example, here is a video where here is a video, for example, where we can see how the dye is moving through the blood vessels. Now in Heidelberg, we have this facility to record the whole movement of the dye, and this definitely is a very interesting feature. So this is how we do the angiography. Now let's see how we interpret a fundus fluorescein angiography report. So there are two things that we look for when we are interpreting a fundus fluorescein angiography, videos or photos. One, is the dye flowing at the expected speed? So when we talk about speed, what is the normal speed or flow? So the depending on the speed, on where the dye is, we divide the flow of the dye into phases. So the normal phases of fundus fluorescein angiography are like this. The first phase is the choroidal phase, which begins 10 to 12 seconds after the dye injection in young patients and 12 to 15 seconds in elderlies. And here the choroid looks very bright white. This is called the choroidal flush. And if the patient has what we call a cilioretinal artery, which is usually supplied by the choroidal vascular system, then it can also get filled at this phase. Now if you see all the retinal blood vessels, they are free of dye. None of them have any dye inside them, so they look black and stand out in sharp contrast to the white choroidal flush in the white background due to the choroidal flush. So this is the first phase, the choroidal phase. The second phase is when the dye starts entering the arteries. This begins 1 to 3 seconds after the choroidal phase, and you can see here the dye is first entering the central retinal artery and then to the arterioles. So this is called the arterial phase. The next phase is the early arteriovenous phase. In this phase, the dye enters the venules, smaller venules, and starts entering the major blood vessels. So you can see here, for example, you see this is the artery getting filled up, the venules getting filled up, and now look here, the dye slowly starting to enter the major veins. So this is early arteriovenous phase, and it is characterized by so-called laminar flow. So laminar flow is this. You can see that the vein is not filling up completely at one go. There are two thin white streams along the borders of the vein with a central dark lumen, or a central or the central lumen being dark. That's because the dye usually enters along the walls of the vein, because the flow of the blood flow is faster along the walls of the vein, and in the center of the vein the blood flow is slow. So usually the vein will start filling up from near its borders, and then slowly the central lumen gets filled up. So this is what we call so if we want, what we can do is we will just pause this. Yeah, so you can see this is what we call a laminar flow. You can see there is a white thin stream along the upper and the lower margin of the vein, but the central lumen or the middle part of the vein is black in color. This is laminar flow. So that was early arteriovenous phase. Then comes the main arteriovenous phase, where slowly the central part of the vein also gets completely filled. So you can see here this arteriovenous laminar flow, slowly the laminar flow is being replaced by complete filling of the blood vessels, complete filling of the vein. So this is also the phase where which is best to visualize the perifoveal capillary network. So this is a magnified view of the angiography, the 30-degree field, where you can see very well. So I'll just pause the image here. So yes, so this you can see the perifoveal capillary plexus very beautifully, and this is important to assess the foveal macular or the macular perfusion status. So this can be affected in various vascular diseases including diabetes, and any capillary dropout or distortion of the foveal capillary network can have a significant effect on vision. So the arteriovenous phase is the best time where you can assess whether the perifoveal capillary plexus is healthy or not. Also, if you see that the fovea appears dark, so the center of the macula appears dark, you can see it in this 30-degree field. Also, let us see the 55-degree field. Again, you can see the central macula, that is the fovea, appears dark. So why is this so? Now there are two reasons. One, the fovea is avascular, so there are no blood vessels at the fovea. We know this is nature's way of ensuring we have highest light sensitivity at fovea. That's why it is thinnest, so that the light can almost directly go and hit the photoreceptors without any other intervening cells. Two, to protect the photoreceptors, the retinal pigment epithelial cells at fovea also have greater amount of pigments, and therefore the fovea appears dark normally in fundus fluorescein angiography in the arteriovenous phase and practically all throughout. Then comes a recirculation phase. This is a less important phase, but this is a phase which begins 30 seconds after the dye injection, and this is where the dye has now gone out of the eye once and returns again. So we will not get to see all those arteriovenous phase and laminar flow this time, but you can suddenly see that the fluorescence which has going down increase a bit and then again fade away. And the last phase is the late phase. By this phase it's almost 10 minutes after the injection, and by this phase that most of the dye has left the eye, and therefore the fluorescence is quite low. Now if we remember all these phases, then while assessing a fundus fluorescein angiography image or video, we have to look at the time at which that video or photo was taken, because then we can estimate whether the dye had reached where it should have reached normally. For example, if you are seeing FFA images, you expect that from the time of injection, within 10 to 15 seconds, the choroidal phase should be over, or at least the blood dye should reach the choroid. But if the dye has not reached the choroid even after 30 seconds, that means it's delayed up to choroid time, and that is not normal. This can happen in, say, ocular ischemic syndrome, when there is a carotid artery blockage, or there is some blockage due to which the blood is not even reaching the choroidal vessels properly. Now, once the blood reaches the choroidal vessels, it should fill the choroid should completely fill up in 3 to 5 seconds. However, if this whole thing takes longer time, that means the choroidal blush is patchy, there are dark patches, or the choroid is not uniformly filling up, or it is taking more than 5 seconds to fill up, that means this is also not normal. There is some delay or some abnormality in the choroidal vessels. But the most commonly seen, or rather should I say, one of the most important times that we note and we monitored is what we call arteriovenous transit time. So this is the time which is taken for the dye to travel from an arteriole to the corresponding vein. So from the arteriole, the dye will enter the capillary, then venule, and then a corresponding vein. So this transit time is usually 8 to 12 seconds. If it is more than 15 seconds, it is abnormal. So let me show you an example of where the arteriovenous time is getting delayed. So look at this patient. Now this is the right eye of a patient. You can look at the inferior blood vessel. You can see the inferior arteries are filled, and now the laminar flow has started. That means the dye has moved from the arteriole to the corresponding vein. But look at the same time at this particular vein. So even though the blood has entered the corresponding vein here, it has not entered this vein at all. It is still dark. And you can see here that the dye is stuck somewhere here. So that's the reason why this vein is still having no dye. So that means here the time that the dye is taking to transit from the artery to the vein is getting delayed. Now let's play the video further. So you can see how slowly the vein, the artery is now getting filled up. But if you look at the inferior blood vessel, now the laminar flow is slowly getting completely filled. That means from early AV phase, we are moving into the AV phase. So now you see this vein is completely more or less filled, but this vein is just starting to fill up with this small laminar flow coming, and yet major part of the vein is not filled up with any dye at all. Yeah, so you can see now this vein is more or less filled. There is some laminar flow still here, but most of these veins are completely filled with dye, but still no dye in these vessels. This means that the flow is delayed in the superior half of the retina. So there is a delayed arteriovenous transit in the superior vessels, probably because of some occlusion in the superior blood vessels. So look out for such abnormality in the flows. This can be global. That means the AV transit may be slow in all the blood vessels, or it can be sectoral, as in this case. So that was the first thing. So you look for each phase and see if the dye is moving as in the way it should move, in the sense if the time that is being taken for the choroidal flush to appear, or the AV transit time and all that is normal, or whether it is delayed at some stage. Because if so, then you record that. Second is, you look at how the dye is flowing through the blood vessels. So one is the speed, the other is whether the dye is remaining within the blood vessels. Because as I said, normally the sodium fluorescein dye does not leak from the blood vessels or does not leak across the retinal pigment epithelial barrier. So a normal flow, if there is a normal flow, the retina would look like something like this, with each retinal blood vessel clearly seen, and there is some background hyperfluorescence due to choroidal flush, but you can see the rest of the eye. This is how a normal fundus fluorescein angiography, or the fundus fluorescein angiography of a normal eye appears. So this is normal pattern. There are now two abnormal patterns which can appear. One is hypofluorescence. So you look here and you can see all these areas, you can see the same uniform choroidal flush as expected with normal blood vessels. But if you see here, the blood vessels are simply missing. This is called pruning. That means as if the branches of these blood vessel have been trimmed, and that is why this area is dark. And this dark area, the darkness is called hypofluorescence. And the other possible abnormality is what we call hyperfluorescence, where you see this area where it is intensely white. Normal whiteness around the macular area is like something like this, but you see here, you can make out that this is intensely white. Compare this macula with this macula. So if you see this area, it is intensely white, and this is what we call hyperfluorescence. So hypo is when you see abnormal dark areas, hyper when you see abnormally white areas. Now let's understand what can cause such abnormal patterns. So if we are talking about hypofluorescence, for example, in this patient, you can see again, this entire area is dark with all the blood vessels missing. Now when we look at the fundus of this patient, we can make out that there is an occluded blood vessel. You can see this blood vessel is simply not filling with blood also, right? It is white. That's because it is occluded, and that is causing the severe ischemia here due to vascular occlusion. Now, so one hypofluorescence may be simply because the blood is not flowing into an area, and therefore the dye is also not reaching that area. So these blood vessels may be thin capillaries, when we call which leads to what we call capillary non-perfusion areas, or it may be major arterioles or venules, as in this case, where you can see this blood vessel, it appears as if it has no branches at all, which is of course not the natural phenomena. Naturally, you will see always there will be an artery will break up into arterioles and then form venules, which will lead to a vein. But if the arterioles and venules are all clogged up, then you will see something like this, where you have this major branch but no arterioles or venules are seen. So one important cause of hypofluorescence is that blood is not flowing or reaching a particular part. So because of vascular occlusion, you can have an ischemia or you can have a black area like this. The other is something like this. So you see here a case where you have this black area, right? But the blood vessels are seen. So what is happening here? Why is this area appearing dark? So if you look at the fundus of this patient, you can make out that there is something under the retina, and this is blocking our view of the choroid. So this is looking normal white because we can see the normal choroidal flush. We can't see the choroidal flush here because there is something subretinal which is blocking our view. So this is what we call blocked fluorescence. Or if you can look at this area, small area here, you see it is intensely dark, much more dark than what we expect a normal fovea to be. And anyway, fovea is somewhere here. This area we do not expect such dark area. Now it is dark because there is a pre-retinal hemorrhage here. So there is blood in front of the retina, which is again blocking the normal retinal whiteness that we expect. So we have now discussed two possible causes of hypofluorescence. One is vascular occlusion, that means blood is simply not reaching an area. Two is blocked fluorescence, where blood may be flowing, or the blood by blood I mean the dye may be flowing, but we are simply unable to see the dye because something is blocking our view of the dye, view of the flow of the dye. Then comes the other pattern, that is hyperfluorescence. For example, in this case, you see this intense white areas, and obviously we don't see anything like that here. So this is somewhat a normal pattern, but this is something unusual, extreme white areas. So this is what we call leak, and this leak is because the blood or the dye along with the blood is leaking out of the blood vessels. So this can happen when there is a abnormal retinal blood vessel. Abnormal retinal blood vessels or new blood vessels leak very easily. They are not so, their integrity is much weak than compared to a normal blood vessel. Their endothelium is leaky, and therefore when we do angiography, abnormal blood vessels NVE and NVDs show up like this intense white light bulb phenomena, as if there's some bulbs are glowing in the dark night. So this is one, and this is another type of leak. You see here, So this is a patient of CSR where you are getting this what we call a smokestack leak, and that's because the blood the dye is leaking across the retinal pigment epithelial barrier. So you can say that normally the RPE separates the choroid from the retinal subretinal space. The choroidal blood vessels leak very easily, very profusely, and naturally that is a normal phenomenon. The choroidal blood vessels leak, so that's why we get the choroidal blush. Now, if the RPE barrier itself is not working, that same dye can enter into the subretinal space, as we can see here, and so this is also a type of leak. Now, how do I understand that this is a leak? So if you have an area of hyperfluorescence, that means it's an intensely white area which keeps increasing in size. So if you look at serial photographs, you will see these white areas becoming more and more, more enlarging. And if somebody asks us to draw the boundary of a leak, it will be difficult, because if you see here, it's fuzzy. You cannot really we can't really make out which is the border, because you see this area is also white, this is intensely white, but the whitening, or the area of whitening is extending beyond that localized white area. So the margin is blurred, and therefore it's difficult to draw an exact or difficult to localize the area within which a leak occurs. And that's why a leak, we call a hyperfluorescence area, as a leaking area if we have the hyperfluorescence increasing constantly. As the dye leaks, naturally it becomes more and more white and also spreading out. So the area of that hyperfluorescence also keeps increasing. Now, second is a hyperfluorescence due to what we call pooling. For example, look at this case. You have again an intense hyperfluorescence, something white. Now, when you look at the fundus photo, you can see this, what we call a retinal arterial macroaneurysm. So this white area and this hyperfluorescent area, the margins are sharp. You can easily make out or you can easily draw a margin around this hyperfluorescent area. So in pooling, when the dye gets localized into something, it's like that there is some gap or space where the dye is getting collected. So here what will happen is the hyperfluorescence will increase, but the intensity of hyperfluorescence will increase, but the area of hyperfluorescence will not increase. It is not leaking out. So the margin will be sharp. So this is pooling. And in leak, as I said, the hyperfluorescence intensity will also increase, and the area of the leak will area of the hyperfluorescence will also increase. And then you have something like this, where you have a patient with a geographic atrophy, and if you do an angiography, you will see this kind of a hyperfluorescence here. Now here the area of hyperfluorescence will correlate with the area of atrophy, and the intensity will increase and then decrease. Why? Because this is what we call a window defect. Now, what is a window defect? Exactly, we understand what a window is, right? So it's like somebody has opened a window into deeper parts of the eye, so that through that window we are able to see the dye which is at a deeper level. So we know below the retina is the choroidal level, and we have already heard about the choroidal flush. So if the retinal RPE or retinal pigment epithelial layer is atrophic, so then we get to see more of the choroidal flush than we normally should. So as the dye moves through the choroid, initially the entire area will become white. Then as it gets flushed out, the entire hyperfluorescent area will go down. So there will be an increase and then subsequent decrease in the intensity of hyperfluorescence. Of course, as I said, the area where you will see this will be matching exactly with the area where there is the atrophy. So the area is fixed. Unlike pooling, the intensity will not keep increasing, but it will increase and then decrease. That is how you can make out a window effect. And the fourth type of hyperfluorescence is what we call staining. For example, in this case of a CNVM, where you can see this area of the CNVM, just look at this area alone, which looks like a scarred. Now here, staining, what will happen is that you will have a slight increase in the hyperfluorescence, but the intensity will be not as intense as a window defect. again the area will be matching or corresponding to the area where we can see the scar clinically, and there will be some amount of hyperfluorescence which will sustain. So in window defect, as the dye gets washed out of the choroid, the hyperfluorescence which was there intensely in the beginning will slowly go away. But in staining, the hyperfluorescence will slowly increase. It will not become very intense like pooling, but it will be more intense than window defect, in the sense in the late phases also there will be some hyperfluorescence. It will sustain, unlike say window defect, because the dye is getting retained inside the scar tissue. So this white is because now the dye has got stuck to this white this scar tissue. So this will be even in recirculation phase or late phase. If you take images, this scar tissue will glow up as a white area. So now these were the four possible causes for hyperfluorescence. So for hyperfluorescence, I said one is that the dye is simply not reaching an area, that is vascular occlusion, or the dye is flowing but we are not able to see it because of blocked fluorescence. And for hyperfluorescence, I said one is the dye may be leaking out through an abnormal blood vessel, that is a leak, or the dye may be getting pulled in an area, in abnormal area, like a retinal arterial macroaneurysm or a pigment epithelial detachment. So where you will have a localized intense hyperfluorescence whose intensity will increase with time but the area will not, unlike a leak where the intensity and area of hyperfluorescence both increases. Third, it may be a window defect where you have an atrophy of the retinal pigment epithelium. So you are getting a window opening into the choroidal flush. So you are seeing more of the choroidal flush than you are expected to see normally. So there the area will be exactly correlating with the area of atrophy. The intensity will increase and then decrease as the dye gets washed out of the choroid. And fourth will be staining, where if there is a scar tissue or sometimes even the disc also, with late phases the disc also can get stained. So if there is a scar tissue or the normal disc also, it will be slightly hyperfluorescent, as the disc or the scar tissue may get stained with the dye. But this hyperfluorescence will not be so intense as say a pooling or a leak, or even for that matter it will be not as intense as a window defect. But it will sustain. It will be mildly hyperfluorescence and it will sustain, and you can easily correlate with the fundus photo to realize that this is a scar tissue which has got stained. So now with all these things in mind, so we now know that when we get an FFA, we should see if the dye was moving in the right speed. We should also see if there are areas of hypo or hyperfluorescence. Now with all that data in mind, let us try to review few FFAs together. For example, this is a 55-degree standard white field rather I should say, not standard, white field fundus fluorescein angiography of a diabetic patient. Now if we just look at this, so we can make out a lot of small white dots. So these are not normal. We can also make out these black areas. We know this is hypofluorescence. This is also not normal. We can also make out some intense hyperfluorescence here. So these are also not normal. So we already see so many multiple abnormalities. We see these small white dots. These are not normal. We have seen these black areas, which is not normal, and also these hyperfluorescent areas or white areas, which also don't appear normal. Now, are they is this a blocked fluorescence or a vascular occlusion? So for that, let us see a later image. So this is the same patient's, a later image of the same patient's eye. Now if you see, there are these few white dots which are still remaining exactly as they were before. So they are still hyperfluorescent, and the area of the white dot has not increased. They have not enlarged. So this is what we call pulling, and these are microaneurysms. So the dye is getting pulled inside the microaneurysms. Now, if you see these white areas, they have become intensely white. So there is leak here. So these are new blood vessels which are leaking. You can see, for example, this white area, it has become so intensely white and it has enlarged in size, right? And then if you look at these black areas, there is nothing which is blocking the view, but it is obvious that the blood is not flowing in these capillaries. So these are capillary non-perfusion areas. So just by looking at the way the pattern of the way the leak pattern has changed, we can make out what is the pathology which is the causing it. So these structures which are leaking profusely are probably not probably, they are neovessels elsewhere, NVEs. This is also the same, and these are capillary non-perfusion areas, and then there are these multiple white dots. Now again, these white dots, if you see, few of them are remaining sharp, and in few of them the hyperfluorescent is not enlarging. So these are non-leaking microaneurysms. But if you look at, for example, this area, if you look at these areas, there are some small white dots which have become fuzzy. That means they are leaking microaneurysms. For example, this is a very good area. If you just compare this area with this area, you can make out that here we can make out the individual dots, white dots. But if we look here, it is very difficult. They are all become fuzzy. So these microaneurysms are leaking. So that is how we can look at each pattern and how it is changing over time and then comment. Now this is another case where again you see this black area, but when you look at the fundus photo, you can make out that there is pre-retinal hemorrhage, which is basically causing this black area. So it is blocked fluorescence. Also there is some vitreous hemorrhage which is causing some of the black areas here, but there is no blood here, and yet you see these black areas. So probably this is where the blood is not flowing normally. So these are areas of capillary non-perfusion. Also, if you look at this blood vessel, it is looking like what we call sausage pattern. So this is venous beading, and this is also not normal. We don't normally see blood vessel getting dilated, and these beading patterns are not normal. These are also signs of severe ischemia. So just by looking at the angiography, we can make out how much of the retina is perfused. For example, this area you can see the blood is flowing freely up to this point, but beyond that the capillaries are blocked. And but look out for the blocked fluorescence, separate that from the vascular occlusions. And then of course we have to think that if there is so much ischemia, whether there is any new blood vessel also, because we can see blood, so there has to be some new blood vessel somewhere which is probably bleeding. Now here we can see there are some abnormal blood vessels here, but we are not sure from where exactly the bleeding is occurring. For that we have to look at later images to see which of the blood vessels are leaking, because a normal blood vessel doesn't leak, and if a blood vessel is leaking, it's an abnormal blood vessel. So here we know, looking at the disc, it is becoming hyperfluorescent and remaining so. You see this, you can't, if I ask you to draw the disc, you can't, because this margin is totally fuzzy. So again, intense hyperfluorescence which is spreading. So we know there is a new vessel at the disc itself. And in these areas, these are not new blood vessels, because again, if you look at these beading areas, you can see with time the hyperfluorescence is going out. So there is no leak here. Just the normal blood vessel has got distorted because of the global ischemia. So you can make out these areas of black areas. These are all areas where capillary non-perfusion is there. So diabetes has caused blockage of the normal capillaries and causing severe ischemia in the retina. So this is how we can assess the angiography step by step. Finally, I will just end with another case. So this is a case of a patient of CSCR. And this is a 30-degree fundus fluorescein angiography picture. So this is the first image. Now you look at the second image and you can make out some white thing coming here. So there is some leakage happening here, something happening here, because you see this hyperfluorescence has appeared from nowhere, and we know fovea is hypofluorescent. That is, it should be dark. We do not expect some white thing in the fovea. And let's see if this increases in intensity and area. So you see the next image, you can easily make out that it is increasing in area. So it is spreading and also increasing in whiteness. So the intensity is also increasing. So it's a leak. So next you look at the next picture. Now you can see this has spread even further. So almost like an umbrella. So this is what we call a smokestack leak. Now if you see carefully, it is getting localized. If you look at this boundary, so the dye is now slowly pulling into the area of retinal detachment. So this is a serous retinal detachment, that is a CSR. So this is the leak site, and from this leak, whatever fluid is coming in the subretinal space is now getting localized, in the area of the detachment. And here you can see that white area becoming, even more white. So which is a classic sign of pooling, that you will have an increase in hyperfluorescence. That means it will become more white, but you can easily make out the margins are not changing. You see, look at this margin and this margin, it is remaining remaining the same. So in leak, you can see as it increases, the hyperfluorescence is increasing, that is the white is increasing, as well as the area of spread is increasing. So this is leak, but this white area is pooling. So there is something here in which the dye is leaking and getting pulled. So the fluid is coming and getting localized or trapped in that area, something like that. I don't know how else to explain. Basically CSR, and this is the margin of the serous detachment, and this is the cause, or this leak is the cause of the serous detachment. So if you see, fluorescein angiography is a dynamic the study. So we have taken serial images, and by studying the images over time, you can make out that the pattern of the abnormality. For example, here we started with a normal looking image, but then something white came up, which kept on increasing in whiteness as well as spread. So we know there is a leak. And then another round area came up, which was increasing in whiteness but not in size. So we know this was an area of pooling. And by this method of analysis, then we can correlate with the disease itself, and then come to a conclusion what is type of disease we are handling, and what is the pathology which is happening, and then plan our treatment accordingly. So when you are evaluating a fluorescein angiography report, check if the speed of the dye's flow is normal. So measure the AV transit time, record the arm to choroid time, record the time it takes for the choroid to fill up. Then look for abnormal fluorescence. Is there any abnormally dark area or abnormally white area? If it's an abnormally dark area, is it a blocked fluorescence or a area of vascular occlusion? If it's an abnormally white area, is it a leak? Is it a pooling? Is it an area of pooling? Is it an area of staining, or is it a window defect? And for that, just keep going back to the fundus photo and then correlate. And that's the most important. Lastly, always remember, when we evaluate a FFA, we don't evaluate it in isolation. We look at the patient. So we look at the clinical findings. What is the patient's complaint? What are the patient's eye findings? Then we look at the fundus. And we also look at the other reports, because there are other tests which may have been done. For example, we may have done a OCT or a OCT angiography also. And then we put all of this together and try to evaluate the FFA report, from which we can understand the extent of the vascular damage, because angiography is basically study of the blood vessels. So you are through FFA trying to make out the degree of damage to the retinal blood vessels, and the severity of the damage. So that is how we try to improve our patient understanding of the patient's disease using fundus fluorescein angiography. So with that, we come to the end of the first part of our series on FFA. In the next part, which I hope I'll be able to share with you soon, I will be first and foremost answering this very important question. We know now we have what we call OCT angiography, which we have already discussed in a video before. You can find it in our channel here. So we know OCT angiography is a non-invasive test. So that means we don't need to inject anything. So naturally, for the patient, it is more comfortable and also safer, because the dye can cause problems, as we have discussed in this presentation. So if that be so, do we really need to do FFAs at all in today's time? Or is it time for us to just bid farewell to the fundus fluorescein angiography machines? And if not, then how do we use FFA in our practice? So I will share both my take on both these questions in the next presentation. Thank you so much for your patient hearing.